the moment. We also have an Eastern Health Center that's at the eastern portion of our county, trying to serve some other people in the county and not require everyone to come to basically the dead center of the county to get sexual health services. Our clinic staff, we're very lucky to have an amazing number of providers. We have 9 providers in our clinic, 2 public health nurses, and 10 disease intervention specialists who really just do such incredible work with everything that they're given. So what I want to talk about first is really talk about where we are with our morbidity in Jefferson County, and just sort of kind of give you an idea of what we're doing with our cases and the numbers that we're seeing. So for gonorrhea and chlamydia and syphilis, so what you'll see here, the green bars are going to be from 2019, the blue from 2020, and the gold or yellow are going to be from 2021 through July. So what you can see is that the 2020 numbers are all basically a little bit lower when compared to 2019. That's mainly because of COVID-19 happening and us having to pull back on our clinical services quite a bit. So our volume was severely impacted. Thus far, just a little bit over halfway through the year, we're quickly approaching our 2020 numbers. I think we're going to end up surpassing them, but we'll see what happens in the end. But we do see a very high number of sexually transmitted infections through our clinic. And so when we say fast track, what do we mean by fast track? And what we're really talking about is a means of basically separating people who have an active symptom of an STI from people who are completely asymptomatic and really just more so interested in being tested for one reason or another. And as I'm sure you all know, there can be a lot of reasons to be tested. Someone thinks that maybe they had a sexual encounter that they're nervous about. Maybe they're just wanting to get tested just so they can stay on top of their sexual health. And the hard part that we had prior to the initiation of fast track was it was sort of difficult to differentiate who was who. And so what would very frequently happen is we would have patients coming in to see our providers, and they would be essentially completely asymptomatic and really were just wanting testing. And so we started to try to think of ways to address that, basically optimize the number of visits that our providers were seeing, where they're seeing people who are actively symptomatic or people who have active sexual health issues that will definitively need to be addressed that day. So what we let this do is it allowed us to basically let people request the service for who are completely asymptomatic. And we wanted them to be able to come in, get the testing they need, and get the peace of mind that they're looking for. And what we really also want to do is making sure that we are trying to evaluate people who are actively having an STI related issue and get them in to see our providers. So what we did with Fast Track is we formally started around the end of 2019. We've had a version of Fast Track that had existed years before. So I arrived at JCDH in 2019. There had been a Fast Track that had been in place a few years ago, but it had kind of fallen to the wayside for any number of reasons. But the real pressing issue that made us do this is because each morning we only do same day appointments at the health department. And each morning patients would call in to try to get an appointment, and those appointments would essentially book up immediately. We had very long wait times on the telephone, and this was creating a lot of anger among our patients, and rightfully so, that they were just wanting to be seen or wanting to be taken care of, and they weren't really having an opportunity to be able to do that. But then COVID-19 hit, and all of a sudden Fast Track became a very desirable option, mainly because we had reduced clinical appointments because we were attempting to allow for social distancing in our waiting room. We were also trying to minimize exposure to our providers of COVID-19 prior to the vaccine. We're still trying to minimize that exposure, but we were really trying to take every precaution that we could to make sure that our providers could be safe. And really what we found is that when we polled the providers, talked to them, said, hey, when you see patients, or how often are you seeing someone who's symptomatic? And they would tell us, oh, not a lot. Like they would tell us, no, we're really not seeing a ton of symptomatic patients. Most of what we see are people who just want testing. And so we really wanted to act upon that and be able to try and implement something that changed it up a little bit. But at the end of the day, I think our biggest concern was our patients were feeling as though their needs weren't being met because they really just couldn't get a hold of an appointment. So the next part was sort of the hard part to do, because we wanted to get word out about Fast Track. And only recently, I think, did we finally crack exactly what we needed to do to make this work. We put it on our website. People do frequent our website a fair amount. When we look at our metrics online, we do get a fair amount of traffic on there. But fast track, I think, is still something that is new to the community, and people had varying levels of comfort with it. One thing that we had talked about for a while was whether or not the fast track visit was actually a good moniker, because we were worried that people would see that and think, oh, well, that means I'm going to get pushed through and not going to get the attention that I need. So we even briefly thought about changing our name around, but what we ended up settling upon was just giving a better definition of what fast track was on our telephone line while people are calling to get an appointment. And that really seemed to sort of smooth things over and get people to feeling comfortable with our fast track process. And then we also started just get patient word of mouth, and people saying, hey, you can go to JCDH, get your testing done really quickly and kind of get on with your day. And we also we're lucky to have a good electronic medical record system where we can get results back to patients very quickly and kind of meet their needs in that way as well. So one of the things that we had to work on was really being able to figure out how are we going to sort out people who are symptomatic from people who are asymptomatic. Because you just ask a patient like, hey, are you having symptoms? And some patients if you ask them that, you might get a yes or no answer. But we really wanted to drill down on it and have a rigorous process so that we can feel confident that when we've labeled someone as being asymptomatic, that we feel that that's true. And what will happen is we've been, again, really lucky to have our public health nurses who are incredibly talented at working through this. They're very experienced with sexual health care, and that they've been able to implement some of these questions, which we'll talk about here just in a moment. So let's go through just some of them really quickly. I'm not going to belabor this, but I just want to give you an example of some of the things that we ask. Does your partner have an STD? Have they been contacted by the health department? Are they having symptoms of STD? Then we would go through and enumerate various symptoms that a person could have, and really try to drill down on what's going on. And certainly anytime a person would have a yes answer here, essentially would result in them being booked to see a patient, booked to see a provider and a priority visit so that we could get them evaluated and see what's going on. But if all the answers are no, we're going to be looking more so to just get the testing that they likely need. We also have some questions that are really focused on males and females and transgender males, transgender females, trying to make sure that we are really, understanding a person's sexual behavior and understanding like sexual sites that may need testing. And so that sort of goes into influence what we pick as far as, the testing that will be offered to a person. And then of course, we have this is what I've done here with these slides is I've sort of broken apart our triage questionnaire that we use for every patient, and that's documented in the chart so that whenever they do come into the clinic, it's obvious what needs to be ordered, what needs to be drawn, and how we need to test the patient. So then what we do is the triage nurse will essentially help to make a disposition for the patient. And like I said, if they have a symptom, they're going to be placed on a priority schedule or on a walk-in schedule. If or they may be pre-booked for a future date. It may just be that we don't have an appointment available today, but we have one available tomorrow or a couple of days from now. And then they'll make sure they have that position secured, and that's sort of outside of that same day scheduling. That our nurses are able to make those appointments without having to, basically because of the allowances that they're capable of in the Athena system. And then if everything else is okay, they're placed on the fast track schedule. In the beginning, we envisioned fast track of being something that was going to be more of a walk-in thing where a person could just walk in at any time and get it. But unfortunately, due to the complications of COVID-19, we have had to limit the walk-in side of that. And that has I think that's sort of the thing that I want to see improved in the coming year or so as we begin to maybe someday move out of COVID-19. Is to be able to see people be able to just walk in and do a fast track, because I think that's much more convenient for our patients and then makes it feel much more accessible. And then, like I said, we also, what we really lean on is that, again, with this particular side of sexual activity is we do lean on self-collected samples, which we'll talk about here in a moment. So, like I said, I mentioned the walk-in already, and what will happen is when they arrive here, so that's where we begin to really lean upon our disease intervention specialists. And as I'm sure you're all aware, disease intervention specialists are incredible at what they do. They're a fountain of knowledge when it comes to sexual health related issues. They're amazing at talking about the prevention of sexually transmitted infections. They're knowledgeable about PrEP, any number of topics that we want to address with the patient. And what we're able to do is when they walk in, when they meet a patient, they can kind of introduce introduce themselves. I can tell them who they are. They can sort of demystify what a DIS is. And our hope is this is sort of it sort of has two purposes. One, we're able to help a patient through a fast track visit, but we're also hoping to demystify what a DIS does, and hopefully sort of build that rapport that's needed in case someone does end up contracting a sexually transmitted infection. They have seen a DIS before. Maybe when a DIS calls, I've heard of that before. I know who you are, what you are. So in a sense, it's almost like a charm offensive where we're putting our DIS out there and really letting them shine and letting them just really work to the top of their ability. So what the DIS will do is, of course, so the DIS already have, it's been a little difficult with COVID-19, but they traditionally have done field visits where, if we're having trouble locating someone, we can do field blood draws, field sample collection. So they're very, very experienced with this. And so they actually help us out to perform those. So they'll draw the HIV and the RPR test, and while they're talking to the patient, giving information, you're talking about other sexual health related issues. Again, this is a good opportunity where they could gauge interest for PrEP if someone is potentially a candidate, and just sort of broach a number of these topics. But then what they do is that they will give some sample collection containers and some swabs so that a patient can collect needed samples for other sexual sites, and really walk them through some instructions that we adapted online for how to collect these samples, and kind of help a patient just figure out what to do and make it comfortable. Because at the end of the day, we want fast track to be viewed as something that other than the needle stick, it should be something that's pretty comfortable and something that shouldn't be a lot of stress for whoever's coming to get it. And then what we do at the end of that is one thing we've been doing is we really push our patient portal. Prior to our patient portal, most of our patients would be calling in to ask for their results, and this created a large volume of phone calls because our clinic, we see tremendous numbers of patients that do perform tremendous numbers of tests, as I'm sure a lot of people out there working those clinics do, and so that does become a bit of a burden. So now we've moved over to the online portal, and as people have gotten younger, as people, I've gotten older, they've gotten younger, we essentially just let them know their results as soon as possible, and I think that's being well received right now. So these are some. So we found these online. We kind of adapted them a little bit to our clinical setting, really letting a person know what they need to do. We have these actually posted in our patient bathrooms where they can be referred what they need to do, be able to read it clearly. And of course, if there are any questions, if there are any concerns about how to perform it, our DIS can walk them through. Certainly if a person didn't feel comfortable doing a self-collection, we could have one of our providers perform a collection. We have other ways of working around that. We haven't really encountered that so far. I think most everyone has been very, very willing to engage in self-collection, and I think it just puts people at ease because they're controlling it. It doesn't feel like it's something that's kind of happening to them. It feels like something that is in their control and that they're kind of working through. And then, of course, we have our vaginal collection and set of instructions as well. So again, all of these are available, easily available for the patients. We have a very large poster so that the person can see very easily what they need to do and how they need to do it. And again, they've got that help there from the DIS. So as far as like what our patients have thought, early on, we had this issue, like I alluded to before, where people thought we weren't giving them like the full level of care. They thought that because they weren't seeing a provider, they weren't getting what they needed. And thank goodness for sexual health, there's, short of having symptoms, it's sort of it's fairly repetitive what we need to do for people, the types of tests that we need to get, the things that we need to be looking for. And so that lends itself very well to this more protocolized type of approach. But yeah, the big thing, patients really, really fixated on wanting to see a provider. And, we was really just sort of kind of helping them move away from that notion of, you can get the exact same level of care without seeing a provider, and that provider can go on to see someone who has an active issue that's going to have to be intervened upon. And then the other part that we did is we had to reassure patients that we will get them the labs absolutely as soon as possible, which we're able to do very, very well right now. And that if there is anything that's positive, a DIS will call them back and let them know, get them in for treatment, and get everything sorted out. And we've said, hey, if you determine that you do have picked up a sexually transmitted infection of some sort, we're going to be calling you. We're going to get you a priority appointment. We're going to get you taken care of. And I think that has been a fairly well-received message. And then there was a little bit of apprehension to set up the self-collection, but I think that's something that we haven't really experienced too much since then. I think people have just generally taken fairly well to that. Let's see. Okay. And again, our biggest intervention, which I think really helped the most, was us basically placing on our wait line saying, hey, here's what fast track is. Let me give you would give a full description of what's going to happen. And it really seemed like after we did that, a lot of these concerns just evaporated, because I think people understood that, we're giving you full attention. It's just a matter of essentially it's sort of breaking up the clinic visit a little bit. And honestly, I think we're seeing these numbers increase fairly quickly. We've had early on, it was a trickle. We've moved to where we're getting large numbers of people going through fast track each week. And what the way I view that is those are added provider visits, is the way I think about that. Meaning that where we're able to have those patients be evaluated in clinic without seeing a provider, what we're able to do is really free up our providers to do what they're trained to do and what they do best. So as far as the test results go, so we're very lucky with how we're able to do some of our labs. So our HIV and RPR labs, so we do send those to an external lab, but they result very quickly, usually within 24 or 48 hours. And those typically come to me, and I'll release them to the patients basically. As soon as I get them into my inbox, I try to stay on top of that so that patients are getting very rapid and very detailed results when they need them. So I do want to talk about our nucleic acid amplification test, because I think that's one of the factors that makes our situation so workable. So the Alabama Department of Public Health has been very generous in allowing us to send all of our nucleic acid amplification tests to them for processing. So we actually do not have to pay for that. So that's a service that is just invaluable to this effort. The downside to it is that it does take a little while for those tests to result. It typically takes 5 to 7 days, and so that can be a little bit of a I think a sticking point for patients, because I think anyone would like to know sooner than later if there's something going on or if they've picked up a sexually transmitted infection. So I think that's probably like the biggest downside to it, is that we do have that time lag that's sort of throwing things off. But again, for us, it's such an amazing benefit for our clinic that we don't even have to think about the finances of nucleic acid amplification tests. And as I'm sure you all know, they can be quite expensive if paid for out of pocket by the patients. The other thing, I don't think it's on here, but I think it's worth mentioning, is when our patients come in, at least for our Jefferson County residents, we only charge a $5 flat fee. Is all we charge. And we've been desperately fighting to keep it that way, just because we feel like higher costs are going to be a barrier to people seeking sexual health care. And we really just want to make this as open and accessible of a clinic as possible. And we're largely able to do that because of the graciousness of the Alabama Department of Public Health. And then, like I said, I mentioned I'm usually the provider who reviews most of these results and sends them to the patients. And again, like I said, positive results are going to be contacted by the DIS directly. So they're typically what we do is we send it over to DIS and they make the call. We tend not to spring a positive result on someone unless they've been contacted by a DIS first, because we just don't want a person to feel as though they don't have someone to talk to, or feel as though that they won't have someone to answer their questions. So that's something typically, if we get a positive test, we don't release that to the patient directly until a DIS provider has made that call. DIS has made that call. So this is just to give you a little bit of an idea of what we saw with our. Let me make sure I've got so if you see the green line, that's our 2019 monthly case numbers. 2020 with the dark blues, you can see not a great year for case numbers. We had a massive drop off in February, March, and April, and then we've slowly clawed our way back up as COVID restrictions kind of allowed us to get a few more patients in. And then what we've had so far in 2021 is we're getting closer to our 2019 levels as far as numbers of patient visits, which I'm very pleased about. So this includes our standard provider visits, and it also includes our fast track visits. But we see a large volume of patients each month, and we really want to keep driving that up as much as possible. And I'm sure our STI rates in Alabama still remain pretty high, so we have a lot of work yet left to do, and we're hoping that this sort of process really makes it much more accessible. So this is just to give you an idea of how kind of where we started with fast track. Now, 2019, we got 43 fast track visits in. So that, like I said, that was just the tail end. So that's why there are so few in 2019. But in 2020, we had 874 fast track visits. Again, I view that as being 874 extra provider visits is the way I see that. It's basically giving us the ability to let our providers see that many more patients, and not having this group of patients sort of mixed in with people who go in to see the provider. And again, if they need it, we'll see them. But if it's just a matter of screening, and I think we're very happy to have them separated into this process where we can get their needs met and also maximize our impact. 2021 so far has been a banner year. We're at July and we're at 616 patients seen so far. I think we're going to well surpass the number of fast track visits that we did in 2020. And I hope we see that trend continue, because it's been very exciting. So the next slide is the one that I'm happiest about, and it's one that I think sort of proves our point, which makes, again, it sort of drives home to me the point that we're doing what we intend to do with this program. So this is basically looking at all of our fast track labs that were from January 1st, 2020 to July 31st, 2021. And what you'll see is that for chlamydia, gonorrhea, and trichomonas, on average, roughly about 10% of those people coming through fast track end up being positive. So to me, that's just an incredible endorsement of this process, saying that, yeah, we are mainly seeing people who don't have an active issue, that we're mainly seeing people who really did not need to see a provider. Of course, that 10%, roughly 10% for those three sexually transmitted infections, of course, they do get seen, they get treated, and we get them taken care of. But the vast majority really just needed the testing. And I think that's, to us, that's great news. As for HIV and syphilis, those rates are much lower as far as the tests go. But one thing I do want to note, one of the limitations about this slide is, we see these total number of visits. So our chlamydia, gonorrhea, and trichomonas are all on the same NAT. So there's a little variation there. But then where you see further variation is, of course, we have our oral, rectal, vaginal, and urine samples as well. So that I think that leads to a little bit of the variability we have here. And you'll see that the HIV and syphilis tests are much closer together. But overall, 7% positivity for all infections is what we see with our fast track screening. So remain very, very pleased with this process and feel like we've made a great contribution to our patients. So talk a little bit more about leveraging our DIS and clinical services. And so I think the two things that really make this program possible is, one, like I mentioned, the NAT test being processed by ADPH, but also it's our DIS. Our DIS are absolutely key to making this happen, and they've been they've been troopers with being willing to kind of step away from their normal duties to help out with this and really bolster this program. But like I said, they're providing instructions. They talk about how to collect the samples, and then they're going to give good STI education. They can answer all sorts of questions related to, how do you treat this? What do you do? How do I prevent spreading it to someone? How do I minimize risk? They can answer all of these questions almost effortlessly. And as I mentioned previously, collecting the blood samples as well. And the other thing too, I think is one of the bigger skills that I think our DIS get really good at is they're tremendously capable with interacting in patients in ways that are non-threatening, in ways that are very helpful, and that they really know how to connect to patients. And I think that's something that is sort of stock and trade for what they do in their line of work, because the DIS has to be able to sort of put a person at ease and really build trust. And I think that helps. And I think that's we have a crew of people here who just completely excel at that and really help make our patients feel at ease and feel comfortable. And the way it works is, so we have 10 DIS at present who do just STD related work, and what they'll do is they split up their duties. So they'll have some who are located in the clinic during the day, and then some people who will be out in the field doing investigations. And so that they'll rotate so as to keep the job, to kind of keep the variety up, and just to make sure that no one's getting bored doing one thing and feeling like they're getting a good set of experiences. Even recently, one thing that we're going to be talking about is while our DIS are out and about, we're really wanting to talk more about COVID-19 vaccines. We're really trying to push into multiple health fronts with their expertise and knowledge, and really trying to take advantage of having a patient who wants to get treated, who may also benefit from other therapies. One of the new things that we're going to be doing here very soon is we have a DIS who's directly dedicated to being a PrEP navigator, working with our social worker in the clinic to help link people to PrEP. And I think when we combine all those things, we're taking every chance that we can to really get a patient as protected and get a patient in as good of a state as they could possibly be when it comes to STIs. And the other thing too is that like I was mentioning before, it's like that introduction of the DIS to a patient. I think that really gives us an opportunity to like just make a connection as to what DIS is, because otherwise, I think if a person got called from a DIS and never having heard of them before, person might be skeptical. And I know that's something that DIS deal with, is trying to work around that feeling of skepticism. So what we have right now, so we have those same day appointments for fast track that are available, for Monday through Friday. Appointment lines open up at 7 a.m. And what we found is that the complaint of patients not being able to get an appointment really does seem to have gone down quite a bit, and we're so very thankful for that. I think that pressure that people feel when they're calling in, where people will call for days and days and days trying to get an appointment, that seems to have gone down because we now have a sort of a pop-off valve to be able to let them get in to be seen and make room for people who are actively having an issue. And it just makes the whole process of scheduling appointments, I think, quite a bit easier. And then also what it is, because the fast track is just that, it's fast. So we can schedule an appointment every 15 minutes. Basically a patient comes in, they check in, and they typically will have talked to the triage nurse before arriving. They check in, the DIS greets them, draw the blood, get the samples. I mean, it is a quick in and out process, and it's something that is a time saver. And I think that's something too, that when we have younger people, by and large, when you look at our patient demographics, who are either working or maybe they had to take off from work, we want to minimize the amount of time that they have to be away and try to decrease the impact of having to come in for any sort of sexual health care. And like I said, they're going to be contacted by the DIS. And also, this also helps our DIS ones, because if they know that the person's been checked out in our clinic, they're able to get the positive test, get them in to be treated, and close these cases out really quickly and kind of move on to the next thing, because we've gotten the problem taken care of. And I think that's been something that our DIS have liked, because it can decrease some of the chasing down that they sometimes have to do when we get reports from other providers in the community. And again, like I said, this has been absolutely essential for us being able to maintain some semblance of normalcy during the pandemic. Because if it had not been for fast track, I think our visits would have been curtailed so much that we would have had a massive negative impact on our local STI rates. And I think I think we're going to be waiting to see what the 2020 numbers look like, but I do suspect that they're going to not look that great. The other thing is that we've really started to try to think more about how to use our DIS for other initiatives. Just an example is hepatitis C. We started providing testing and treatment for hepatitis C in 2017. And what we've really wanted to do is just let people know that these resources exist. And sometimes that's the best part about what a DIS can do, is when they make that contact, they can help people with these things that they may not even know about, let them know about services they're not even aware of. And patients may now receive hepatitis C antibody testing during this fast track visit. We don't do that quite as often, but it is available to patients, and we have been doing it increasingly here. Actually, Dr. Sanders she actually was spearheaded the founding of our hepatitis C treatment clinic, and that's been such a great resource, because we've been able to get a lot of people treated, and really have been able to kind of help some people out who may not otherwise not have been able to access that care, and that's something we're very proud of. And of course, if they do have a positive test for hepatitis C, we reach out to them, we get them set up for appointments, and we get them set up for treatment. That's become a lot easier as more insurances have sort of relaxed some of their requirements for it, and also we've had decent luck with getting medications directly from the drug companies through the help of our social workers. So that's been a tremendous boon for this. But yeah, our social workers just are absolutely amazing in helping us find some of these treatments, and we're I have to say it's a little bit different beast. It's not quite the same $5 fee, but we're able to do a sliding scale fee that makes it, sliding scale fee that makes it affordable for our patients who live in Jefferson County. That's one of the restrictions that sometimes we have to work under, is that we often have to limit some of our activities to people who live in Jefferson County, being the county health department, but we'll do everything we can to help people who come to us. The other thing is that we've been working on is that we've started to try to branch out into a different way, a little bit of a different way of doing PrEP. And again, this was something that came out of having to deal with the COVID-19 pandemic. We have a robust PrEP clinic, and again, that's something that Dr. Sanders was able to spearhead and get started. And what we've been seeing is, of course, as everyone's heard this with PrEP visits, it's basically 4 visits a year. To be seen, get tested, and get a renewal of the medications if you're doing it by the book. But of course, we also look at who gets PrEP, and it's going to be younger people who maybe have never had a medical condition before, or chronic medical condition that would require being seen by a provider that frequently. And so that's something that we started to think about, is like, well, what could we do to make this a little bit more palatable to a younger audience? And again, this was pre-pandemic. We were thinking about implementing it, but then it sort of forced our hands during the pandemic, and that was teleprep. And initially, we had started to think about doing like video visits, like sort of like a secure Athena or other EMR type video visit. But we had a great conversation with one of our UAB telehealth experts, and we realized just how very complicated that can be, and realized that the actual video visits just created many extra layers of complexity that may not actually make it all that feasible for us as being a very small clinic. So what we ended up settling upon was, when we say tele, we mean telephone, not as in a digital visit, but it's just a telephone visit. And what we started to offer is we would say patients would come in for their establishment visit. They would come in for all the needed labs, counseling that would be required, and then subsequent visits would be conducted by telephone, where our providers would go through and make sure that the patients were doing okay, answer if they have questions, query about side effects. But then the lab portion would actually be handled through Fast Track, meaning that we would send our patients, say, okay, well, we've talked to you, go get your labs, and when you've got your labs in, we'll renew your prescription. So that again, you're able to get a telephone visit that can be more accessible to a patient, where maybe they could step away, talk to you on a break. They could do it a little bit more on their own time, and then also be able to come in for the lab visit on their own time. And that was fairly well received. We're still working on building that up a little bit more, so that we can have more people utilizing that. But it's been kind of interesting, a little bit paradoxical. It seems as though a lot of patients said, oh no, they just prefer to come in to see the provider. So we're just sort of shooting in the dark sometimes, I think, with what people want, or trying to guess what people want. But we're leaving the option open, because I do think that there are people who maybe will have constrained schedules that will be benefited by not having to stick tightly to a visit that could take a little while, and that gives them a lot more flexibility. So that's something that we're still trying to build out just a little bit more. I think other than that, I think that's the main things I wanted to get over, and just in summary, I just want to say that, our Fast Track experience has been good. I think it's probably going to be a little bit, I think it's great if a place can do this and they can do it without too many monetary concerns. And that, again, that's our big benefit that we had, is that Alabama Department of Public Health really made it easy for us to do this. But we have had a great experience with it so far. It's something we're going to try to keep going as long as possible. And I hope we continue to expand it and really offer these services to as many people as possible. The next big goals that we have our Eastern Medical Center that we're trying to get Fast Track up and running in, trying to get clinical visits up and running in. Right now, we're trying to drum up support for it, and really trying to let people know that this is out there and serving a geographically different portion of the county. We also have a Western Health Center as well that we hope to expand to maybe in the next year or two, but we want to make sure we're fully utilizing our Eastern Health Center before we do that, so that we're really getting the most bang for our buck when it comes to our providers. But with that, we can open up for questions and open up for discussion.
Awesome. Thank you so much for your presentation. We do have a bunch of questions that we can start working through. Our first one, and by the way, some of these were definitely covered in your presentation, but I figure if they're asked, let's make sure people get the information. So our first question is, are rapid HIV tests given during fast track visits, or is it all venipuncture?
So it's all venipuncture right now. So we have we have rapid tests that are available. We're mainly using those at the moment more so for rapid PrEP initiation is the way we're leaning into it at the moment.
Okay. How long have y'all been using the fast track system?
Really since 2019. Before we used it for about a year and then it stopped and just kind of died down. So 2019 to present.
Nice. So this was not just a COVID innovation. This was something that you had handy in the back pocket. That's great. A compliment. Somebody said great presentation, and their question was, what happens at the front end of the clinic? So that's kind of interesting. What does it look like there in terms of registration and paying for services?
So we use the freezer pad, and this is something we started using during COVID. So patients are actually able to register themselves like before they even enter the building. They can pay their $5 fee before they enter the building, or if they don't have access to a telephone or a way to use that registration system, then they can come in the building and pay and register. And that seems to be working out well. It's made us a lot more effective and efficient.
So following self-collection, oh, you know what? There's a follow-up question. What's the name of that system?
It's Freesia, P-H-R, I think it's E-E-S-I-A.
I'm just gonna type that in there so everyone's got it. So P-H-R?
Uh-huh.
A...
E?
E?
It may be one E or two E's, S-I-A.
I've never spelled it the same way twice.
I think that might be right. Correct me if I'm wrong, but okay, awesome, thank you. So following that self-collection part where the patient collects their own samples, how are the specimens handled from there?
So before the patients actually collect their samples, after the DIS talk to them, they go ahead and label the tubes. They put the patient's name on it and they label the site of collection. Then the patients actually collect their samples, stick them in the tube, and we've got like a little box that goes to the lab. And so once they've got the top on, they put them in that box and our lab techs take them over from there. And the DIS actually complete a requisition for each one of those tests.
So is the DIS also involved in sort of that review of those procedures then? I know when I used to work in clinic, there was a temptation of patients to just stick the swab right through the foil, and there's a lot of interesting interpretations on what should be done after collection.
We still have some patients that stick it straight through the foil. So, we really stress that you need to unscrew the cap and break it at that little perforated part on the stick.
Awesome. Something that comes up a lot, and I know you touched on this in the presentation, but just billing can be somewhat complicated. So how do you navigate that with your express visits? Is it different from how you would navigate the everyday visit in terms of billing? Because I think that's definitely of interest for a lot of folks here.
Currently, we don't bill for our fast track services or for our routine STD visits. So there's a $5 flat fee for all of our patients. We may bill at some point in the future, but right now it's just a flat fee.
Okay. Do you have plans to add the new NAT test for Mycoplasma genitalium in your fast track clinics?
That's a good question. So not at the moment. Oh boy, gosh, I'm afraid that would open up just a can of worms. So we We do utilize the NAT test for mycoplasma, but typically what we do is we for our patients who come in who are symptomatic, because we don't preemptively screen for or do like we would with the gonorrhea, chlamydia, trichomonas. So what we do is it's like a person comes in, non-gonococcal urethritis. We treat them. If they don't get better, they come back. Then what we do is we will then test for mycoplasma. We have some. I don't know. We don't think we have necessarily a lot here, but we have enough that we see it fairly frequently. I think the hard part really becomes is just like our treatment options are not always the best, and so I think at the moment we would not add that into the screening, but that is something that we do in our clinic, is we are able to get that test.
Speaking of testing for other pathogens, one of the questions in the chat just popped up. Do you test everybody for trichomoniasis?
We do.
That's exciting to hear. I know it's funny how the reportability of things sometimes dictates what gets tested for. So it's interesting to see. It's always good to, I think, offer patients a very robust panel, but that's just opinion here. So do fast track patients with positive STI test results receive treatment only during their treatment visit, or do they also receive a physical exam by a provider when they come back?
It depends. So if it's syphilis, they're definitely going to receive a physical exam so we can really stage it and identify any lesions that they may have. If they're still asymptomatic, so not reporting a discharge or anything for gonorrhea, chlamydia, or trichomonas, then they just receive treatment. And of course, we ask about medical history and allergies and things.
This next question is a little bit more on the capacity building and logistical end. Did the DIS who work in your clinic get extra training to do the triage work for fast track? Because it seems like they were playing a pretty important role in all of that.
So I'm sorry, there's a fire drill going on here. But the DIS do not do the triage. It's actually the public health nurses.
Okay. How do you all conduct field visits safely with COVID being a concern? Do your DIS transport patients, or is there something else, some other mechanism to bring patients into the clinic?
So what we've had, basically, I'm sorry for the background noise. I apologize. I'm going to try not to get too distracted. Essentially, we curtailed it for a long period of time. Once vaccinations were available and a very adequate amount of time had been given, we began to allow that a little bit more. We try to be selective about it and try to really gauge who needs it the most. But we still have been doing transports back to the clinic, and we still have been doing field visits. And at most of the time it can be conducted, in a decently safe manner, but we also have been providing appropriate PPE for our DIS.
Our audience is looking for some assurance.
I'm really dedicated to this talk, and I can take the burns.
Oh, please don't. If at any point you do need to vacate, we can always truncate our program for today. And we can roll with the punches. If 2020 taught us anything, is rolling with the punches. So I do want to make sure everyone there is all set with that. We do have a few more questions, but I think what we could do is possibly follow up with those as you relocate. So please take your time. And, it's almost a metaphor for, how we've gotten into these situations. So thank you all for your phenomenal questions. I think given the circumstances, we will allow you all to just wrap, and I will look through the questions that remain, and we can always send those out to folks as we get answers. So thank you so much, everybody, for attending this great webinar. We're going to have a recording that will go out. And again, we'll follow up with some answers, but please everyone stay safe. Don't mess with the fire marshals, and have a great afternoon.
Thank you. We're very
Thanks for attending.
Thank you.
No need to apologize. This is all about rolling with the punches. So have a great afternoon, folks. Thanks so much. Bye-bye.
All right. Bye.